Hello everybody. Now we are going to discuss the basics of ECG. So all of you know that ECG or EKG stands for electrocardiogram, the recording. On the other hand, the terms electrocardiograph means the machines which is going to record the ECG. Now ECG is composed of multiple waves, we all know that, and those waves are known as the P, Q, R, S and T waves. P wave, by definition, we all know that it is the first wave which is appearing in the ECG due to atrial depolarization. Then if I ask you what is Q wave by definition it is the first negative wave which appears after the P wave. Okay, so this is the definition, that it should be a negative wave after P. If a positive wave is appearing after the P wave, that will be known as the R wave. So R wave is the first positive wave after P wave. Why I am saying this? Because in some of the ECG lead you will get a recording like this, P wave, then you are directly getting a positive wave followed by a negative wave. In some of the lead you are going to get this kind of recording. In these cases obviously this will be known as the P wave, that is the first wave, and this positive wave which is appearing after P, this will be known as the R wave, not the Q wave, because Q wave by definition it is the first negative wave after P wave. So obviously after the R wave the next wave is going to come is the S wave and this is the T wave. Okay, similarly here also you are getting this S wave which is appearing after the R wave, right? Now in some abnormal ECG you may get a positive wave after this S wave also. Suppose you are getting again a positive wave like here. Okay, so in that cases, so this is R, this is S, and now I am getting a positive wave like this. So in that cases this will be known as the R dash or R dot wave, right? So RS R dot pattern, we say like this, RS R dot pattern, this is seen in some of the abnormal ECG. So this is the different namings of the waves in ECG. Now we have to understand what is the meaning of this ECG, how the ECG is originating in the heart. So if I ask you what is ECG, you can recall your MBBS days that you used to answer that it is nothing but electrical activity of the heart. Now in the previous chapter also we have discussed another electrical activity, that is the action potential on the heart muscle. So these two electrical activity, they are different or they are same? What is the relationship between this action potential and ECG? We are going to understand that first, right? So to understand this topic, suppose I have taken a single myocardium cell. So this is the single myocardium cell. Maybe this is a ventricular muscle cell. Suppose this is a ventricular muscle cell. Now in this myocardium cell, if I put one electrode inside the cell and one electrode outside the cell, right? So what I am doing, look at, I am putting one electrode inside the cell and one electrode outside the cell, and in between these two electrode I am putting a recording instrument. What I am going to get in this recording instrument, I am going to get the voltage changes activity, and that voltage change activity is nothing but generation of an action potential. This is a monophagic action potential. The ionic basis of this action potential we have discussed earlier, right? So what is the placement of electrode? Note down, one electrode inside the cell and one electrode outside the cell membrane. Monophagic, only one phase action potential you are getting, right? Now rather than a single cell, if I take a portion of the myocardium, suppose I have taken a portion of the myocardium, suppose this I have taken from the ventricular muscle, a large portion of the ventricular muscle. So this is a tissue basically, you can say like this. we all know that it is composed of multiple cells, and those cells are electrically connected with one another with the help of gap junction. We all know this. Okay, in the previous discussion we have already discussed this. So they are electrically connected with one another with the help of this gap junction. So now, rather than placing the electrode inside the cell, if I put both the electrode on the surface of this tissue, so I am putting electrode and both the electrode are placed on the surface of this tissue, and I am going to record this electrical activity changes of this muscle tissue. What I am going to record? I am going to record the ECG like this. So what is the meaning of this? Meaning, if you place both the electrode on the surface of a tissue, then you are going to get a biphasic potential recording. Biphasic. What do you mean by biphasic? Biphasic potential means some part is above the baseline, some part is below the baseline. So you are getting a biphasic potential, and that biphasic electrical potential is nothing but known as ECG. Getting my point? So this biphasic potential you are recording by both the surface electrode, and this is a group of muscle cell. So if you place one electrode inside the cell, right, one electrode outside the cell, and you are recording electrical activity from a single cell, then you are getting the normal action potential. But rather than taking a single cell, if I take a group of cell and if I place both the electrode on the surface of this group of cell, then you are going to get an ECG, and that ECG is nothing but summated version of all the action potential which is generated inside this cell. What is the meaning? Meaning, whenever this tissue is stimulated, this cell will also produce an action potential, right? This nearby cell will also produce an action potential, this will also produce action potential, and this is also going to produce action potential. And whenever your electrode are placed on the surface, you are going to get a summated version of all this action potential, and that summated version of all this action potential is ECG. So I can write down like this, that ECG is nothing but summated version of all the action potential which is generated in a group of myocardium cell, right? So this is the difference between these two. Okay, both of them are similar kind of electrical activity, but one is recorded from a single cell, another is recorded from multiple cell. So now if you look at this action potential, we all know that this phase is known as the phase number 0, and phase number 0 is known as depolarization phase, right? So if I ask you that phase number 0 indicate ventricular depolarization, in ECG which waves indicate ventricular depolarization? QRS complex. So ideally, if you are saying that ECG is nothing but summated version of action potential, then this depolarization or this phase 0 should coincides with origin of the QRS complex also? Answer is yes. Why not? So whenever you are getting phase 0 in normal action potential, you are going to get the Q wave in normal ECG. And similarly, if I ask you what is the meaning of this phase 3 in normal action potential, you will say that phase 3 is nothing but repolarization. In ECG, which wave indicate repolarization? We all know the T wave. So in action potential, end of repolarization should coincide with the end of T wave also? Answer is why not? Yes. So this will correspond with the end of T wave. That means I can understand that phase 0 in action potential is coincides with the QRS complex onset, and phase 3 ending is coinciding with end of T wave. That means if I measure the time duration of this whole action potential, this is known as action potential duration. This will be same to same with that of the time interval between Q and T, which is known as QT interval. Answer is yes. So that's why we write like this, that action potential duration on myocardium, action potential duration of myocardium cell is equal to QT interval, which is normally 200 to 400 millisecond. Getting my point? So QT interval is equal to the action potential duration of the myocardium, which is normally 200 to 400 millisecond, right? And we just came to know that your ECG is nothing but summated version of all the action potential which is appearing in the myocardium. Now you may thinking that, sir, you are talking about the QRS complex. What about P wave? Okay. POA means rather than taking this ventricular muscle, if you take this from atrium muscle, again you are going to get an action potential like this. But the duration of this action potential in case of atrium muscle is only 1/3 of the ventricular muscle action potential duration. That's why whenever you record the ECG from this atrium muscle, so suppose this is the atrium muscle group, if you record the ECG from that, you are not going to get the waves which are like that of the QRS complex. You are going to get this P wave. Getting my point? So the action potential duration of the atrium muscle is 1/3 of the ventricular action potential duration, right? And that's why the shape of atrial depolarization is not like that of the QRS complex, right? So after understanding this, if I want to understand a more detail, that sir, you are saying that APD, action potential duration, is equal to the QT interval in case of ventricular muscle. So if I change the slope of the phase 0, what will happen to the ECG? Getting my point? Suppose I am changing, okay, the slope of this phase 0. So it is becoming slower like this. It is becoming slower like this. So the slope of phase 0 is changing. It is slowly rising upward. Why it will rise slowly? The phase 0 is due to opening of sodium channel, and that is voltage gated sodium channel. So if you give a drug which is blocking voltage gated sodium channel, that will cause decrease in the slope of the phase 0, right? So slow rise of phase 0, or if you decrease the slope of phase 0, the QRS complex will be prolonged. Getting my point? So please note down this important feature, that decrease phase 0 slope, right, will leads to prolongation of the QRS complex duration. QRS complex duration will be increased. And who is going to decrease the phase 0 slope? That is voltage gated sodium channel blocker. All of you know that voltage gated sodium channel blockers are class 1 anti-arrhythmic agent. So if I draw a normal action potential like this, okay, try to understand. So suppose this is the normal action potential, okay. If I give a class 1 anti-arrhythmic agent, suppose I am giving class 1A, so it will reduce the slope of action potential like this, right? So this is 1A. Similarly, the 1B also reduces the slope of phase 0, but lesser than that of the 1A. And 1C, all of you know, that decreases the slope of phase 0 to a maximum. So this is the most potent one, 1C, okay, decreasing the slope of phase 0 maximally. Similarly, I can easily understand that this 1A antiarrhythmic agent, 1B antiarrhythmic agent, and 1C, all these three class of antiarrhythmic agent, they are going to reduce the slope of phase 0. That means all of them will increases the QRS complex duration, but maximum increment of duration will be done by 1C and minimum will be done by 1B, right? Next is that if any drug is causing prolongation of this phase number 2 or prolongation of this phase number 3, then what is going to happen? I can understand that if it is prolonging phase number 2 or phase number 3, then the action potential will look like this. In that cases, what will happen to this action potential duration? Action potential duration will increase, and we have seen earlier that action potential duration is equal to the QT interval. So if you increase the action potential duration, your QT interval will also be prolonged. So I am writing here the second feature, right? That is, if any drug is prolonging or increasing phase 2 or phase 3, right? So obviously what is going to happen? The QT interval will also be prolonged. And all of you know that this class 1A antiarrhythmic agent, they are going to causes the prolongation of this action potential duration. So this is 1A. So similarly 1A is also going to causes QT prolongation, right? 1B is going to decrease the action potential duration rather than increase. It is going to decrease the action potential duration rather than increase. So obviously 1B group of drug is going to causes shortening of the QT interval, and 1C is not going to change the action potential duration. So QT interval is not going to change in case of class 1C antiarrhythmic agent. Getting my point? So this way, if you read by combining the physiology and pharmacology, your concept will be more better. Okay, so please try to understand this thing. If you don't, listen once again. Now next thing that we have to understand is that in ECG we are recording the potential or voltage from the surface. Okay, here I told you that I have placed 2 electrodes on the surface of this myocardium. But normally when we record ECG, we do not place the electrode on the surface of the heart. Okay, rather we place the electrode on the surface of the body. So we all know this phenomena, that suppose this is our body, okay, this is the torso, okay, and heart is located here. So human body is a very good conductor of electricity. So whatever voltage is originating here, the same voltage will reach to the surface of your body. Whatever voltage is generated here, the same voltage is going to reach on the surface of the body, because our body is a very good conductor of electricity. That's why although we are discussing that as if we have placed 2 electrodes on the surface of the heart, but actual ECG does not places electrode on the surface of the heart, rather we place electrode on the surface of the skin. But it will make no differences, because human body is a very good conductor of electricity, right? Next thing is that there is another problem with surface recording. That is not actually problem, but another understanding. What is that? So whenever you are saying depolarization, we know that interior of the cell will be positive and outside will be negative. That is the meaning of depolarization. We know this concept. In ECG, we are recording the potential from the surface. So whenever depolarization is going on, obviously the interior of the cell is becoming positive, but the ECG electrode is going to get the negative charges, negative voltage. Getting my point? So in ECG electrode, if I say it is getting negative, it is touching the negative surface, that means the interior is positive. That means this is nothing but depolarization going on in the cell. I hope this is also clear, right? Now try to understand. Okay, try to understand. So suppose I have 2 myocardium cell connected with one another. 2 myocardium cell connected with one another. In between them there will be presence of gap junction, and there will be presence of intercalated disc. So all these things we have discussed earlier, okay, and gap junction will also be present here. Fine. So they are electrically connected. Now imagine that one depolarization wave is moving from one cell to other cell. Depolarization wave is moving, right? Okay. So whenever this depolarization is moving, suppose already just hold on. Suppose already this cell is depolarized, means interior is positive and outside is negative. Okay, so negative means the depolarization is going on. And the rest of the cell, suppose this cell is still in the resting condition. So this is resting condition, and in the left side cell the depolarization is going on. So depolarization means already negative charge has developed, and this depolarization is going towards the next cell. Next cell is still in resting condition, means inside is negative, outside is positive, right? So now I can easily understand here that there is separation of two different kind of charges on the surface of these two cells. On one side is negative charge on the surface, and on one side positive charge on surface. So there is separation of these two charges. Because of the separation of these positive and negative charges, there will be creation of an electrical dipole. There will be creation of an electrical dipole. And whenever there is creation of an electrical dipole, what is going to happen? Current will start flowing from positive towards negative. So the current will start flowing from these positive charges towards the negative charges. We all know that this is nothing but I. I stands for current, right? So I hope you are understanding this diagram. Okay, so current start flowing on the surface of this muscle, and we all know current flows from positive to negative. So this tiny current are flowing on the surface, right? Due to the flowing of this current, there will be generation of a potential difference on the surface of the cell. So to record this potential difference, okay, so just hold on. Okay, to record the potential difference, if I connect one voltmeter on the surface of this myocardium, so this is my voltmeter, the positive end of the voltmeter is connected here, and the negative end of the voltmeter is touching here. So this is the negative end of the voltmeter, this is the positive end of the voltmeter, right? Voltmeter. What the voltmeter is going to do? The voltmeter is going to measure the potential difference between this and this end, between these two ends, positive and negative end. This potential difference is nothing but recording of voltage. So whenever there is flow of tiny current on the surface of this myocardium, what is happening? If you connect one voltmeter, the voltmeter is going to record the potential difference between these 2 points, and this potential difference is nothing but voltage. Now all of you know that voltage is an vectorial quantity. So voltage vector, vectorial quantity. Vectorial quantity means we all know that it will have a particular amplitude, right, and it will have a particular direction, right? So vector will have a particular amplitude and particular direction. So if I ask you, what is the direction of voltage vector that is created here, your answer will be voltage vector is directed from negative towards positive. So negative towards positive, this is the direction of voltage vector, and this voltage vector is recorded by ECG machines. So repeat once again. Yes. So ECG machines, you know, it consists of very sensitive voltmeter. Very sensitive voltmeter is there inside the ECG machines. And what the voltmeter is going to record? It is going to record the potential difference. It is going to record the voltage vector which is generated on the surface of the heart. What is the direction of the voltage vector? It is directed from negative towards the positive. What is the amplitude of the voltage vector? The amplitude of the voltage vector depends on how much muscle mass is depolarizing simultaneously. If the muscle mass is more, then voltage vector amplitude will also be more, and if the muscle mass is thin, the voltage vector amplitude will be less. So basically now we came to understand that ECG machines is recording voltage vector whenever it is created on the surface of the heart. Right. To understand this topic, okay, more grossly, okay, I am drawing the surface of the atrium here. So suppose this is your atrium surface, right? And obviously this is ventricle. Okay. So whatever concept just now I discussed, we are discussing the same thing with a different view. Okay. So here your SA node is located. Okay, and whenever SA node started production of impulses, we know that it is going to stimulate the nearby cell. So this cell is going to be depolarized. Depolarized means inside will be positive, and this depolarization will spread rapidly to the other cells because these cells are electrically connected with one another via gap junction, right? But we are least interested in inside voltage, because we are discussing ECG. ECG means we have to look what is happening on the surface. So if inside is becoming positive, then outside is negative, 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 like this. So suppose only this portion of the atrium muscle is depolarized. Depolarization is spreading, but for our understanding, we are understanding that this portion is depolarized now. And the rest portion of the atrium, okay, they are not depolarized, means inside is still negative and outside is positive. Outside is positive, right? So this is still in resting condition. So this is still in resting condition, right? Same here, this is resting condition, resting condition, resting condition, resting condition. So now again the same thing, that tiny current will start flowing on the surface of the heart, and that current will flow from positive to negative. So this tiny current will flow from this positive to negative direction, that I can understand. But we have to discuss what is happening to the voltage vector. Okay, so look at, I am deleting all these things so that the diagram looks clearer. Okay, so now you think of voltage vector. I told you voltage vector is directed from negative towards positive direction. So I can understand that there will be creation of multiple voltage vector, and that will be directed in all the direction. If you think of the three-dimensional picture, right, think of like this, that you are looking from the surface, looking at the surface of this atrium, and on the atrium surface multiple voltage vector are directed in all different angle, and all these voltage vector are directed from this negative towards this positive. All these small vectors which are created at a particular point of time, these are known as the instant vector. These are known as the instant vectors, right? So instant vector means the vectors, multiple vectors which are created at a particular instances, that is instant vector. Do you think that the ECG machines or the voltmeter is going to record all these individual instant vectors? Answer is no, that's not possible. So I have to understand that what is the net voltage vector, what is the summated version of voltage vector, what is the direction of that, what is the amplitude of that. So you all know that although multiple voltage vectors are created, but if you look at the net or mean vector, that vector will be directed from SA nodes towards the AV node, because we all know that ultimately the depolarization is going from the SA node towards the AV node. So if I look at the summarized version of all this instant vector, that is known as instantaneous mean vector. Instantaneous mean vector, right? So this is known as instantaneous mean vector. So please remember, instant vector means all the small vector which are created at any instances, and if you take the mean or average or the summated version of that, that is known as instantaneous mean vector. Getting my point? And ECG machines record the instantaneous mean vector only. So getting my point? Okay, so this is nothing but going to be recorded by the ECG machines, right? So whenever the atrium muscles are depolarized, there will be creation of a different instantaneous mean vector. When the ventricular muscles are depolarizing, there will be creation of a different instantaneous mean vector, and that instantaneous mean vector will be recorded by ECG machines, right? So this is the overview or basic concept of generation of the ECG. Now look at the book. I have taken a diagram from book. The same thing that we have discussed, it is given in this book here. So this is the heart. Okay, this is the heart, and you can find out here the depolarization is going on, and due to depolarization you are finding out that there is creation of a negative charge surface and there is creation of a positive charge surface, and that is generating a voltage vector which is directed from negative to positive, right? This voltage vector is going to be recorded by ECG machine. For the recording we have placed these two electrodes, right? We have placed these two electrodes, and these electrodes are connected to this voltmeter. So this ECG machines, it is nothing but the voltmeter, okay, and this voltmeter is recording the potential difference between this, and this potential difference is nothing but voltage, and voltage is a vectorial quantity, right? So this way you have to understand that ECG is nothing but recording of voltage vector, particularly the instantaneous mean vector. So suppose the atrial depolarization is going on, right? So just now we have understood that there will be generation of a voltage vector. So this is suppose your instantaneous mean vector. Okay, now how this instantaneous mean vector is going to give waves in the ECG? Very simple. So suppose this instantaneous mean vector is created due to atrium depolarization. So it is going to give rise to P wave in the ECG. Okay, now if I ask you that suppose one lead is connected here, okay, and another lead is connected here, okay, so I can understand that voltage vector is neither directed towards this lead or neither directed towards this lead, okay, this lead, right? So what will happen to the voltage vector amplitude in the direction of these two lead, right? And that is simply done by vectorial analysis. And how that will be done? Look at, suppose the amplitude of this voltage vector is 4, or suppose this is 5 millivolt, right? Suppose the amplitude of this voltage vector is 5 millivolt. What will be the amplitude of this voltage vector in this lead and this other lead? How to calculate that? Simply you have to draw one perpendicular from this on the axis of this lead and drop another perpendicular from here on the axis of this lead. Or you can do by mathematics also. If you know this angle theta, suppose this angle is theta, then all of you know that this will be cos theta, right? Okay, amplitude of this vector, suppose that is A, so A cos theta will be the amplitude. But rather than doing this mathematics, if I draw a perpendicular from here on this axis and perpendicular from this here on the other axis, then I will know the amplitude of this voltage vector in this two direction. So suppose that amplitude is 1, 2. Suppose this is 2 millivolt here, and here suppose this is also 2 millivolt, right? So what is the net amplitude of this voltage vector? 5 millivolt. Okay, and if I divide this voltage vector towards this lead, that is 2 millivolt, and the other lead, that is also 2 millivolt. So if a lead is connected here which is directly facing the voltage vector, suppose this lead is recording this 5 millivolt voltage and it is giving a wave which is 5 millimeter height. Suppose this height is 5 millimeter. So obvious thing is that I am going to get a similar kind of wave in this lead also, but the height of this wave will be 2 millimeter, and similarly in the other lead the height of wave will also be 2 millimeter, like this. Getting my point? But if your lead is placed just opposite to this voltage vector, suppose one lead is here, then this lead will record a wave which will be negative rather than positive wave, and the amplitude will be almost similar to this 5 millimeter amplitude if it is just opposite to this lead. right? So this way the voltage vector will be recorded by different leads in different manner. Okay, and how can I understand that if the voltage vector is directed towards a particular lead, how this voltage vector will be recorded by a different lead? You have to do the vectorial analysis either by mathematics or by dropping perpendicular from the mean vector on the axis of that lead. Getting my point? So this way you have to divide, but all this wave, because these waves are generated due to this atrial depolarization, we call them as P wave, P wave, P wave and P wave. So all of them are P wave. All of them are generated by a single voltage vector, and this voltage vector is nothing but instantaneous mean vector, which is generated due to atrial depolarization. But look at the amplitude of this P wave is not equal in all these lead. The amplitude will be different according to the mathematics, according to the vectorial analysis, right? So whenever we are discussing this different P wave in different leads, again we are saying leads. Okay, so first of all I have to understand what is the placement of different lead in the ECG, and then only I will be able to understand clearly how the QRS complex will looks different in different lead, because QRS complex has multiple wave, Q wave, R wave, S wave. P wave is simple. Okay, P wave I can imagine that it will be simple wave, but to understand the QRS complex, first of all I have to understand the different leads in the ECG, and then I will understand how the QRS complex is generated. So P wave generation is done. Okay, now we all know that there are 12 leads in a standard ECG. 12 leads means 3 leads are there which are known as the bipolar standard limb leads. So standard bipolar limb leads, how many of them are there? So 3. Then you also know that 3 augmented limb leads are also there, and 6 precordial leads are there. Precordial leads are also known as the chest leads, right? Precordial leads are also known as chest lead. Now look at the bipolar standard limb lead. They were first time discovered by William Einthoven, we all know, right? Augmented limb lead were discovered by Emanuel Goldberger, and precordial or chest lead was discovered by Frank Wilson, right? So standard bipolar limb leads, we all know that they are known as lead 1, lead 2 and lead 3, right? Augmented unipolar leads, they are known as AVR, AVL and AVF, right? We all know this thing, AVR, AVL and AVF. And chest leads or precordial leads, 6 in number, they are known as V1, V2, V3 up to V6. So how these leads are connected on body surface, that we are going to understand first, right? So standard bipolar limb leads, lead 1, lead 2, lead 3. Look at the word bipolar. Okay, so I have to understand what is the meaning of bipolar, but before that I hope all of you know that for ECG leads 3 reference point is taken. One is right acromion, left acromion and symphysis pubis. These are 3 reference point for connection of ECG lead, and that is according to William Einthoven's description, right? So this is by convention, right acromion, left acromion and symphysis. But whenever we are saying that reference points for ECG lead attachment is right acromion, left acromion and symphysis, you may start thinking that, sir, in normal ECG recording, we never place the lead on the acromion, but we place the lead here, just above the wrist. So what is the difference between these two? Why there is difference? Look at. So I told you that human body is a very good conductor of electricity, and it is known as volume conductor. So heart is located here. So it is generating some current. That current is reaching on the left acromion region, suppose. Now this arm, it is nothing but extension from a volume conductor. If you imagine that this is a volume conductor, So these arms are nothing but they are extension from the volume conductor. What do you mean by that? Means whatever amount of electrical current is reaching at this left acromion point, the same current is going to flow through this whole arm without any change. Similarly, whatever current is reaching at the level of this right acromion, the same current is going to flow through this whole arm, and similarly, whatever current is there in the symphysis pubis, the same current is going to flow through the left leg. That's why it is said that this right arm, left arm or the left foot, they are the extension from the volume conductor. The current flow will not be different even if you take this left acromion or the tip of this finger. The everywhere, whether you placed your electrode here or here or here or here, it will make no difference. But due to our easiness, we place the electrode just above the wrist. Okay, that is easier. That way, so you have to remember that electrical current which is reaching at the tip of acromion, it will be same throughout this whole limb. So you can place your electrode anywhere, right? Now another question that, sir, you are saying left leg, why not right leg? If it is symphysis pubis, then the same current will flow in the right leg also. Answer is yes. But according to William Einthoven's description, okay, by convention we use the left leg. Right leg is taken as the grounding for ECG machines, right? So you can take the right leg also, but by convention, by discovery, we follow this left leg. Okay, so our 3 reference point just we came to know. Just let me delete all this thing. Okay, so 3 reference point is nothing but to acromion and the symphysis, but I told you the meaning of this. Okay, now I told that this standard bipolar limb leads means, bipolar means both the electrodes are active electrode. What do you mean by that, sir? Okay, so I told you that ECG machines is nothing but a voltmeter. So this is my voltmeter, this is the negative end of the voltmeter, this is the positive end of the voltmeter. If you connect the negative end on one part and positive end on other part, and if you measure the difference between positive with respect to negative, suppose positive is getting plus 5 and this is getting plus 2, then bipolar limb leads means it is going to measure the difference between positive minus negative. That means both the electrode here are active electrodes, both of them are recording some potential, and you are measuring the difference between these two, and that's why this is known as bipolar leads. Getting my point? But suppose I have placed my voltmeter in such a way, okay, so this is another voltmeter. Here I have connected this negative end and positive end, but the negative end is connected to a point where the voltage is near equal to 0 millivolt or 0 volt, or you may better say that this voltage is a fixed voltage, this 0 volt, and this 0 volt is not changing. Okay. So now this 0 volt point or this fixed voltage point is known as indifferent electrode, and the other electrode is going to record the voltage from the surface, and this electrode will be known as the active electrode or exploding electrode. Means now the active electrode is measuring a voltage with respect to 0, with respect to a fixed voltage. That voltage is not going to change. So this voltage which is not going to change, which is the fixed voltage, that is known as indifferent electrode. So unipolar lead means one electrode is indifferent and another electrode is the active electrode or exploding electrode. But bipolar recording means both the electrodes are active electrode. The negative end is also getting some voltage, positive end is also occurring some voltage, and you are measuring the difference between them, and that is known as the bipolar recording. Getting my point? So this is the meaning of simple bipolar and unipolar recording. Now I told you that standard bipolar limb leads are 3: lead 1, lead 2, lead 3. So how you are going to connect your voltmeter for lead 1 recording? Right. So this is my voltmeter. if I connect the negative end of the voltmeter to the right arm and the positive end of the voltmeter to the left arm, then that lead is known as lead 1, right? So this will record. So how have I connected? I have connected the negative end of the voltmeter to the right acromion and positive end of the voltmeter to the left acromion. So you are going to record a potential difference between these 2 points, positive minus negative, that is the potential difference. This potential difference will be known as the potential difference of lead 1, bipolar lead 1. I told you potential difference is nothing but voltage vector. So voltage vector means it will be directed from negative towards positive. So the lead 1 is directed from this negative towards this positive. I hope I am clear, right? So this is the direction of this voltage vector from negative towards positive, because I told you voltage vector is directed from negative to positive, right? So this is which one? This is lead 1. Now connect lead 2. Lead 2, this is the voltmeter. If the negative end of the voltmeter is connected to the right arm and if the positive end of the voltmeter is connected to the left foot, right? Negative end to the right arm and positive end to the left foot. Again, you are going to get a voltage vector recording which is directed from negative to positive, and this voltage vector is nothing but voltage vector of lead 2. So this is nothing but my lead 2, right? Similarly, if I ask you connect lead 3, so this is my voltmeter. The negative end of the voltmeter is connected to the left arm and the positive end of the voltmeter is connected to the left foot. So one voltage vector is directed from negative towards positive end, and this voltage vector which is directed from negative towards positive end, this is nothing but voltage vector of lead 3. Getting my point? So these are the connection of voltmeter for recording of 3 standard bipolar limb leads, lead 1, lead 2, lead 3. So you must be thinking that, sir, again and again you are saying voltmeter, voltmeter, voltmeter. Where these voltmeters are located? This is located inside the ECG machines, I told you already. And there are particular circuit there. If you ask the ECG machine to record lead 1, he will calculate the potential difference between this left arm with respect to right arm voltage. If you instruct the ECG machine to record the lead 2, he will calculate the potential difference which is recorded from here with respect to right arm. If you ask the ECG machines to record the lead 3, then he will calculate the voltage or potential difference between this with respect to this left arm. That is the meaning of these 3 bipolar standard limits, right? So now I came to know that 3 bipolar limb leads, this is 1, this is lead 2 and this is lead 3. What they are making? They are making a basically triangle. Look at this. Okay, make it clear. So this is 1. So basically they are making a triangle, and this triangle is an equilateral inverted triangle with the heart at the center, and this is known as your very famous Einthoven triangle. Getting my point? So this is very simple. What I told, I am writing here. So this is lead 1, okay, this is lead 2 and this is lead 3. This is making a equilateral triangle, and this triangle is known as Einthoven triangle. Now you also know that the voltage vector or any vector can be shifted parallelly, means from one region you can shift to the other region parallelly without changing the amplitude, without changing the direction, right? So I want to change the vector of this lead 1. So lead 1 was originally here. Now I am parallelly shifting this to here. So this is now the new location of lead 1. I want to shift parallelly this lead 2 also. So this was the original position of lead 2. I am parallelly shifting this lead 2 here. So this is new lead 2. And this is lead 3. I am parallelly shifting this lead 3 from here to here. without changing the amplitude, without changing the direction. What you are finding out? All these three vectors are meeting with one another at the center. With respect to this center, the direction of this lead 1 is known as 0 degree. The direction of this lead 2 is known as 60 degree, and the direction of this lead 3 is known as 120 degree. This is the positive direction, and this opposite one will be the negative direction. So this is known as hexaxial referral system of ECG. You will understand a little bit more, okay, but for the timing you remember that how the center is created, from where 0 degree, 20, 60 degree, 120 degree is calculated. What I am doing, if this is lead 1, I am parallelly shifting this lead 1. If this is lead 2, I am shifting this lead 2 here, and if this is lead 3, I am parallelly shifting this lead 3 here. So all these three vectors are meeting a center, at a center. From this center, this lead 1 direction is known as 0 degree by convention, lead 2 direction or angle is known as 60 degree, and lead 3 by convention, this is 120 degree. Getting my point? So this is the referring system for the ECG. Okay, so you have to understand this. So I just came to know that this lead 1, lead 2, lead 3, they are making a triangle, and if you parallelly shift this three vector, they are meeting a center. From their lead 1 direction is 0 degree, right? I hope you understood the concept of bipolar limb leads. Now there is a problem in front of you. Okay, so suppose due to depolarization of the heart, there is development of certain voltage, okay, potential at the level of left arm, right arm and left foot or symphysis, whatever. This three voltage is given. Suppose this is an image based question. These three voltage are given, right? Where? Okay, here. Now you have to calculate that in your ECG machines, how much voltage will be recorded by lead 1, right? What I told you, lead 1? Lead 1 means I told you that it is the left arm voltage minus right arm potential or voltage, right? So look at here, what is that? So, okay, just hold on. So lead 1 means it is the left arm minus right arm. So left arm is 0.3, okay, plus minus 2 is in the right arm, right? So obviously this will be plus 0.5 millivolt. So this amplitude will be recorded by lead 1, bipolar lead 1 in ECG machines. Similarly, if I ask you calculate the lead 2 from here, so you have to just, this is positive and this is negative. So lead 2 means I have to do that L left foot minus right arm. So this is 1 millivolt minus 0. This is minus 0.2 millivolt. So it will be plus 1.2 millivolt. Right? I hope you're getting it. And lead 3, if I ask you to calculate, so how you are going to do this? This is nothing but 1 millivolt, it is positive, minus 0.3 millivolt, right? So this is positive. So obviously this will be 0.7 millivolt, 0.7 millivolt, right? So this is 0.7 millivolt. This is plus 1.2 millivolt and this is 0.5 millivolt. Getting my point? So this way the three bipolar standard limb leads are calculated by the ECG machines. So are you getting any relationship between this lead 1 voltage, lead 2 voltage or lead 3 voltage? Answer is yes. Lead 2 voltage, if you look at lead 2 voltage is equal to the lead 1 voltage plus lead 3 voltage. See, right? So this is 1.2 millivolt, which is equal to the 0.5 plus 0.7, that is equal to, so 2 is equal to 1 plus 3. This is complex mathematics. 2 is equal to 1 plus 3, right? And this is known as Einthoven law. Amthoven law, right? So voltage in the lead 2 will be equal to the voltage in the lead 1 plus lead 3. This is Amthoven law. So this is all about the bipolar standard limb leads. Now coming to the augmented limb leads. This is unipolar lead. The previous one we have discussed the bipolar lead. So here this is the unipolar lead. So unipolar lead means I told you already, one is the active electrode and one is the indifferent or inactive electrode, right? So active or exploding electrode and one is indifferent or inactive electrode. So what do you mean by this augmented limb leads? Okay, augmentation means you are simply increasing the voltage. Like for example, suppose the heart was generating a voltage which is 10 millivolt at the level of left arm point, left arm or left acromion. If I augment this voltage to 15 millivolt and if it is recorded by ECG machine, that is known as simple augmentation of the voltage. And how much voltage is augmented? 5 millivolt means 50% augmentation of voltage is happening. The same thing is done by augmented limb leads in the ECG. It increases or augments the voltage. How much voltage is increased? 50% increase in voltage. Increase in voltage is done by augmented leads. So how that is done? Okay, this is done by certain changing in connection in the circuit of the ECG machines. So how that circuit is done, right? Okay, so try to understand. Suppose I want to record the augmented VR. Okay, augmented VR means I want to augment this right arm voltage, that is known as A. A stands for augmented, V stands for voltage, R stands for right arm. I want to augment the voltage of the right arm, right? So how to connect the voltmeter? So this is my voltmeter. The positive end of the voltmeter has to be connected at the level of this right arm. Okay, so this is the active electrode. Now I have to find out one indifferent point where the voltage will be near equal to 0. How to do that? Okay, so this other two reference point, that is the left arm reference point and this left foot reference point, they are connected with one another. But in this connection, I have given a high resistance near equal to 5000 ohm resistance is given. So whenever you are giving this huge amount of resistance, if I ask you what will happen to the current flow at this point, obviously current flow will be near equal to 0. So what will be the potential in this point? The potential will be near equal to 0. Okay, but although I am saying this is near equal to 0, mathematically the potential here will be equal to voltage of the left arm plus voltage of the left foot upon 2. What I am saying? Suppose the voltage which is generated at the level of left arm, that is VL, and the voltage which is generated at the left foot, that is VF. So whenever I am connecting these two, the voltage at this connecting point will be average of these two voltage, right? Although that average is near equal to 0, that is not going to change, that is fixed. But mathematically this is average, okay, but practically this is near equal to 0. Now if I connect the negative end of my voltmeter at this 0 point, then you are creating a circuit, and this circuit is known as augmented VR circuit. Getting my point? So what I am doing, if I want to augment a point, the other 2 points has to be connected first, and that will make an indifferent point, right? Similarly, if I ask you, I want to produce this connection. Which connection? Augmented AVL, right? So previously we have discussed AVR. Now if I want to produce this AVL, A for augmented, V is the voltage, L is the left arm. So what I am going to do, I am going to connect, okay, my positive end of galvanometer, a positive end of the voltmeter to the left arm region, that is this one here, left arm region, right? And the right arm as well as the left foot or left leg, this has to be connected through a high resistance. So this will be as the indifferent electrode. So this positive and negative in between, if you connect a voltmeter, this is nothing but your AVL recording, right? Similarly, if you want to produce this AVF, so A for augmented, V for voltage, F for foot. Foot means left foot. So what I have to do, my voltmeter should be connected in such a way that this positive end of voltmeter will be connected here, and the other 2 points, they has to be connected through a high resistance like this, and then the negative end of the voltmeter will be connected here. This way I can produce the AVF, right? So if you connect the circuit in this way, what will happen? Your voltage will be augmented, your voltage will be increased by mathematical formula. So how much percentage of voltage is going to be increased? I told you already, that is 50% increment of voltage. So please remember, augmented lead means it is nothing but increment of voltage, and that is 50%, right? So what is the direction of these augmented leads? So please try to recall. Previously we have discussed that lead 1 is directed and that is 0 degree. Lead 2 direction is 60 degree and lead 3 direction is 120. That is a bipolar leads. Here I have also given the direction of the augmented leads. AVR, it is directed in minus 150 degree angle. AVL, it is directed at minus 30 degree angle, and AVF, it is directed at 90 degree angle. So now this referring system, here the 6 leads are there, lead 1, lead 2, lead 3, AVR, AVL, AVL. This referring system in ECG is known as hexaxial reference system. Getting my point? So hexaxial reference system, note down this diagram. So here this is the lead 1, okay, this is the lead 2, this is the lead 3. Then augmented AVL, AVR, and this is AVF, right? So I can understand that this is the positive and the opposite one, this is the negative, right? Very easy. So from the center, if I go towards this right hand side, then this is the positive axis of the lead 1. If I go in the opposite side, this is the negative axis of lead 1. Similarly, if you look at here, this is the positive axis of lead 2 from the center towards this downward direction. If you go in this opposite direction, this is the negative direction of the lead 2. And similarly, the other leads are also plotted. So this is known as hexaxial referral system for ECG, right? So we are done with the bipolar leads and augmented limb leads, right? Now here comes your chest lead or precordial lead. So all of you know the chest lead, they are located on the surface of this precordium, the chest wall which is overlying the heart, that is precordium. So the chest lead will be located on this precordial area. Now there is a basic difference between the 6 lead that we have discussed earlier and this chest lead. What is the basic difference? All these 6 lead that we have discussed here, they are located in the coronal plane or frontal plane. So lead here, here, here in downward direction. All these leads, they are looking the heart from the coronal plane. Getting my point? Suppose lead 1. So lead 1 is directed like this. Okay, they are looking the heart in a coronal plane. So this coronal or frontal plane. But whenever I am placing a lead over the surface of this precordium, it is looking the heart from the horizontal plane. Getting my point? So this way, first you remember that chest lead or precordial lead, they are looking the heart from a horizontal view, and other 6 lead that we have discussed, they are placed in the frontal plane or coronal plane. Right. Now the how chest leads are connected. So chest lead, again they are the unipolar lead, right? Unipolar lead means again you require one active electrode, one indifferent electrode, right? So to create the chest lead, first of all I have to connect this three referral point at the center. So all these 3 points are connected through a high resistance, right? So you are creating a central, this is known as central terminal of, this is known as central terminal of Wilson. So what I am doing here? Simple. Whatever we have done earlier, that we are giving high resistance, and we are connecting all 3. So obvious thing is that at this center, if I ask you what will be the potential, this potential will be near equal to 0 potential, but mathematically we know this 0 potential is nothing but this is the voltage of right arm, this is the voltage of left arm, this is the voltage of left foot upon 3, but mathematically that is equal to 0, right? That is mathematically equal to 0. Now if you connect a voltmeter with the negative end of the voltmeter, okay, so this is voltmeter, negative end of the voltmeter is connected with this central terminal and positive end of the voltmeter is connected to the chest wall, then this is the circuit of chest lead. Now we all know that there are 6 chest lead, V1 to V6. So V1 means you have to connect this active electrode or the positive end of the voltmeter. This is the active electrode. You have to connect this active electrode to a particular position. The position for V1 we all know, that is the right side of the sternum, 4th intercostal space. So if I connect this positive end of the voltmeter at 4th intercostal space on right side of the sternum, then whatever voltage will be recorded by this voltmeter, that will be known as the V1 voltage. If I connect this active electrode at the point of apex bit, that will record the voltage of V4 lead. Similarly, if you connect this active electrode to a different area which is for V6, then it is going to give you the potential difference or voltage of V6. So getting my point? So chest lead means the active electrodes will be placed in different location on the precordium, and inactive lead is placed at the central terminal of Wilson, right? So that way you have to remember the location of these various chest lead. Okay, so I am not taking much of the time here, all of you know this. V1 means right side of the sternum, 4th intercostal space, right? And V4 means it is the left mid clavicular line, 5th intercostal space, that is the apex beat ka position, right? The position of the apex beat. Similarly, the V2 left side of the sternum, same intercostal space, okay, and V3 is placed in between V2 and V4. Then V5 and V6 is same. All of them are the same 5th intercostal space, all of them, that is the 5th intercostal space region, right? But the V4 is mid clavicular, V5 is anterior axillary line, and V6 is mid axillary line, right? So this is the difference. One is mid clavicular, anterior axilla, and mid axillary line. So this way you have to remember the position, and you can find out here the negative input of the voltmeter is connected to the Wilson terminal or central terminal of Wilson, right? So this is about the chest lead, and I told you already the chest lead, they are placed in which plane? Horizontal plane. They are looking the heart from the horizontal surface. This is the position of V1 on the right side of the sternum, V2 on the left side of the sternum, and this is the V6 from the mid axillary line. So they are looking the heart in different angle, right? Now question is, all these leads we have discussed, what these leads are doing, why you record so many leads, and why this lead, what does the job of this lead, right? Harrison is saying these leads are nothing but they are like a video camera. These video camera are recording the voltage vector, that voltage vector which I have discussed earlier, the mean the instantaneous mean voltage vector, right? That voltage vector is moving in different direction inside the heart, and that voltage vector, you have to take the snapshot of those voltage vector, right? So these cameras are nothing but leads. The leads are nothing but camera. They are taking the snapshot of voltage vector, right? Then the next question, that if this camera are connected in different angle, we know the position of those cameras. Now how this QRS complex will be generated? So before this diagram, I hope all of you have understood that how the P wave is generated. That is due to atrial depolarization, and I have given you one voltage vector and we analyzed that voltage vector earlier. Now let's discuss this QRS complex generation, right? So QRS complex will be generated due to ventricular depolarization. You have to recall that ventricular depolarization starts from which part? Could you recall that? That is the septum, interventricular septum. Which part of the septum? That is the mid part of the septum. So this is the point, this red color point, where the septal depolarization starts. That is the mid part of the septum, interventricular septum on the left side. Then what is going to happen? Then the voltage vector, then the depolarization will move from left to right, and this depolarization will leads up to the level of apex. So now I can understand that due to septal depolarization, multiple voltage vectors are created, right? So these are instant vector, but I require a mean. That is the instantaneous mean vector, which will be recorded by voltmeter or ECG machines. So the instantaneous mean vector for this septal depolarization is known as initial vector. Getting my point? So this is known as initial vector. Please note down. So initial vector, look at the direction and look at the color and look at the thickness. Everything matters here. Then what is going to happen? Then all of you know that whenever up to the apex is depolarized, next both the ventricular muscle is going to be depolarized simultaneously. So this is your left ventricle, this is your right ventricle, both the ventricular muscle is going to be depolarized simultaneously, right? After this simultaneous depolarization, okay, so when this simultaneous depolarization of the muscle is going on, what is going to happen, you know? There will be again creation of a instantaneous mean vector, and that vector is directed like this, which is known as main vector. What I am saying? Main vector. Okay, main vector. Why? Because this vector is produced due to ventricular muscle depolarization. And look at the direction. This is directed towards the left side. Why? Although this vector is generated due to right and left ventricular muscle depolarization, but we know that left ventricular muscle thickness is more than right ventricular muscle thickness. That's why the vector is slightly deviated towards the left side. And then we know that the base of the heart is going to be depolarized. For the depolarization of the base of the heart, the vector which is going to be created is known as terminal vector. Getting my point? So now to summarize, for atrial depolarization, we have seen only one instantaneous mean vector which was coming from SA node towards the AV node, and this vector has given us the generation of the P wave. Already that has been generated. But the ventricular depolarization is a complex one, where the septal is depolarized first, which is generating initial vector, then the both ventricle is depolarized, which is giving rise to the main vector, and then the base of the ventricle is depolarized, which is giving rise to the terminal vector. So during ventricular depolarization, three instantaneous mean vectors are created, which has to be recorded by voltmeter or ECG machines. Let's see how these are recorded by ECG machines. So this is the schematic diagram of the ventricle and different leads. Which leads? The 6 leads which are in coronal plane. So first we will be discussing the leads which are in coronal plane. So lead 1, lead 2, lead 3, I know what is the direction of them, okay, and lead AVR, AVL, AVF, we also know the direction of them. So first septum will be depolarized, initial vector will be created. So here comes this initial vector. Now for this initial vector, which lead is going to give you positive recording? How to understand that? If you draw a perpendicular on this voltage vector, any leads which are located on this side, they will give you the positive recording, and any leads which are located on other side, they will give you the negative recording. Getting my point? That is by vectorial analysis. And if I ask you which lead will give maximum positivity, the lead which is facing directly this voltage vector, it will give you the maximum positivity, and the leads which are facing it from the side, they will give you the small positivity. Getting my point? Getting my point? So this way, if you look at this, so this initial vector is giving generation of the red color wave in the ECG. So look at here, this is one ECG recording, okay, this is the recording of the AVR, this is the recording of the lead 3, this is the recording of the AVF, okay, this is the recording of the lead 2, this is lead 1 recording, and this is AVL recording. You are getting here, right? So try to understand. So look at this red color, look at this red color, okay. Initial vector is giving a small wave in lead 3, lead AVF, and it is giving a negative wave in AVL as well as lead 1, but it is giving a positive wave in lead 3 and lead AVF, right? Okay, next is what? Next is the main vector is coming. So the green color main vector, thickness is more because ventricular muscle mass is more. So now you tell me which leads are going to give you the positive. Again the same thing I am going to do. If I draw a perpendicular on this green color vector, then all the leads which are on this direction, they will give you the positive deflection. So let's see how this green color wave is developed. So look at this big green color wave, okay. So it is giving a positive wave here, okay. This is also giving a positive wave here, this is also giving a positive wave here, right? So this green color is due to main vector, and then the terminal vector is coming here, blue color, small terminal vector, the depolarization of the base. So now which leads are going to give you positive? Only the AVR, because this vector is directed in this direction, AVR direction, so that is going to give you positive. All other leads are going to give you the negative. So similarly I am drawing here this blue color, okay. Look at this blue color, so it is negative here, so this is S wave, this is also negative here, S, this is also negative here, S, this is negative, okay, this is small negative here. And now the ventricular depolarization is over. So whenever ventricular depolarization is over, there will be no current flowing on the surface of the heart, and that will create an isoelectric line. So this black color line is the isoelectric line, and this way your QRS complex is generated. Getting my point? So step by step I have shown you. Now you again come back here. So this is the diagram that we have discussed earlier. So red color means this is the initial vector. For this initial vector I am getting a positive recording in this lead 3 and lead AVF. I am getting a positive recording, right? And for the same red color vector I am getting a negative in AVL and lead 1, right? So the name of this first negative wave after the P wave is nothing but Q wave, because I told you already the P wave is generated, that is due to atrium depolarization. So P wave already been generated here, P wave already been generated here. So the first negative wave is Q wave. But are you getting any Q wave here? Are you getting any Q wave here? Answer is no, because septal depolarization is giving a positive recording in this lead 3 and lead AVF. That's why I am not getting any Q wave in these two leads. Then next is what? Next look at this green color and look at the recording. This is giving big positive wave here also, here also, here also, here also. So these are known as the R wave, R wave, R wave. But if you look at the AVR, in AVR this R wave is a big negative, because the location of the AVR is just opposite to the voltage vector, right? That's why it is giving negative. And then if you look at this terminal vector, it is giving a small positive wave in the AVR, but it is giving negative S wave, S wave, S wave in all other leads. Getting my point? So this way the QRS complex is generated due to 3 vector, right? Due to 3 instantaneous mean vector. Which lead we have discussed? We have discussed all the 6 lead which are present in coronal plane or frontal plane. Now if you look at the precordial leads, the same 3 voltage vector will be there, but precordial leads, they are located in the horizontal plane. I told you already. So look at here, the same thing, okay, same thing. So here the V1, blue color V1, okay, I'll take the different color. So blue color V1. So you have to imagine like this, that this is your cross section of the chest wall, okay, V1 lead is here, V2 lead is here, and this is the V6, and you have to imagine that this is your heart. So this is my septum. So when the ventricular depolarization is occurring, the first wave will be the initial vector. So look at, if this is the initial vector, it is coming towards the V1. So what kind of wave you are going to get in V1? You are going to get a positive wave. So this is not the Q wave. But if I look at V6, this initial vector is going away from V6. So this V6 will give you a negative wave like this. So this way, if you analyze the precordial lead voltage vector also, you are also going to get that no Q wave in V1, no Q wave in V2 also, but there will be presence of Q wave in V5 and V6 lead also, right? And due to the movement of this voltage vector from this septal, so septal vector is from left to right direction, and then the ventricular muscle, when it is depolarized, the vector is moving towards the left. So because the voltage vector is moving towards the left, if you look at the positive wave or the R wave, what you are finding out that R wave is gradually, okay, increasing towards the left side of the chest wall. So this height of the R wave is gradually rising like this, and a little decrease in V6. So this gradual increase in height of the R wave is known as progression of R wave towards the left side of the lead. Now you may be thinking that why it is maximum in V5 and in V6 there is a little decrease. Okay, why it is maximum in V5 and there is a little decrease in V6? Look at this V1, V3, V4, V5, all these, they are very close to the heart. But V6, because they are in the mid axillary line, the lung is causing a little hindrance for this V6 voltage recording, and that way the voltage is little lesser than V5. V5 is very close to heart surface, so there will be gradual increase. So V6 should be highest, but because of the hindrance of the lung, the V6 voltage is a little lower than V5. Okay, so this is known as progression of R wave in precordial leads. So now we came to know the detailed recording of P wave as well as QRS complex in different lead. Now question is, sir, why do you require so many leads, 12 leads ECG? Why you require so many leads? Okay, so you can look at the diagram, one apple, right? So if you want to know that whether the apple is good or bad, is there any damage in any part of the apple, then you have to look at all the surface of the apple, right? That if there is a small portion which is damaged or not, then you have to look from all the surface. And the same way, heart is a three-dimensional structure. If I want to understand that which part of the wall is damaged due to infraction or ischemia, then I have to attach different cameras from different angle, and that is done by 12 lead ECG. I told you already that leads are nothing but like a video cameras. They are giving you images of different wall. So I have to remember that which wall will be recorded by which lead, right? So suppose I am getting an ST elevation on V1 and V2 lead. then which wall is damaged? The anteroseptal wall is damaged. Similarly, if you are getting changes in V3 and V4, then it is giving the information of anterior wall, right? Lateral wall, the V5, V6, 1 and AVL. You have to imagine one lead one in this direction, AVL in this direction. So AVL, V5, V6, they are all the left sided lead. So that's why they are giving you information about the lateral wall of the heart. And inferior wall, very easy. Lead 3 is here, lead 2 is here, and AVF is here. So all these 3 leads, they are going to give you the information on inferior wall of the ventricle. So any kind of changes, suppose ST elevation or ST depression, if you are getting in this lead, that indicate that the lateral wall of the ventricle is damaged. If you are getting changes here, then the inferior wall is damaged. So this way you have to remember the different leads and different wall of the heart, right? Now we are coming to the normal ECG, how it looks like. So we have already discussed that how different wave will be recorded by different lead. So lead 1, 2 and 3, they are the bipolar standard limb lead. The recording will be biphasic in them. Biphasic means some part will be positive, some part will be negative, like this. Biphasic means some part will be negative, some part will be positive, like this, right? AVR, very peculiar lead. AVR, almost all the waves are in negative deflection. AVL and AVF, again you are going to get a biphasic recording in them. Now comes the most important one, that is a V1 and V2. I told you already that Q wave is not seen in V1 and V2 normally. If you are getting a Q wave in V1 and V2, that indicate pathology and mostly old case of myocardial infarction, right? So V1 and V2, no Q wave is seen and deep S wave will be seen. Just opposite will be seen in V5 and V6, small Q wave and tall R wave will be seen. And in between this V3 and V4, they will get the biphasic recording. So biphasic recording is seen in bipolar limb leads also, AVL, AVF also, as well as V3, V4 also, and rest the leads, some different recording is there that I have to remember, right? Now from the normal ECG, I also have to remember certain duration and interval. This is very easy, all of you know mostly, but again I will discuss. So this is a beautiful recording of a normal ECG taken mostly from the lead 2. First you note down the isoelectric line. I told you isoelectric line means when no current is flowing on the surface of the heart. Isoelectric, right? That is the baseline of the ECG. Okay. After the full depolarization of the ventricle and after the full repolarization of the ventricle. So this point, this is after the full depolarization and this is after the full repolarization. They are mainly the isoelectric line, although after the P wave also I am also finding out an isoelectric line, right? Now you all know that PR interval is very important for your MCQ. So it starts from the onset of the P wave up to the onset of the Q wave. If Q wave is not there, onset of R wave will be taken. Then you are also finding out the QRS interval, right? That is the duration of the QRS complex, right? Then you are finding out here is a J point, right? So all of you know that the J point is that point where this S wave is ending. This S wave is ending and it is leading to generation of an isoelectric line. So where this S wave is ending and isoelectric line is starting, that point is known as the J point. After this J point, the next part, this isoelectric line is known as the ST segment. This is known as ST segment. This is very important because the depression or elevation of this ST segment, okay, will be an important topic for your discussion in medicine. Okay, you know that myocardial infarction or ischemia will leads to changes in this ST segment, right? And other QT interval that we have already discussed from the starting of Q up to the end of T, that is the QT interval. Now I have to remember the duration of this thing, right? So PR interval, this is must know information, 0.12 to 0.2 second. right? Then QRS complex. We have earlier seen that Q wave, if it is there in the ECG, that Q wave is generated due to septal depolarization. So please remember, Q wave means that is the septal depolarization, R wave means that is the ventricular depolarization, and S wave means this is the depolarization of the base of the ventricle. This is important again, right? ST segment I told you earlier, and this QT interval I told you that 200 to 400 millisecond is the duration, so it is written here. This is again a must know information. Other you may remember, but this thing which I have discussed just now is very important for your MCQ. Now I told you that the PR interval has a duration of 0.12 to 0.2 second. So how to calculate this duration from ECG, or how to calculate the heart rate from ECG? All of you know this thing, but I will discuss them quickly. So this is the normal ECG paper you all have seen, right? So to understand the duration, you have to understand that what is the speed of this ECG recording paper. Means this paper on which the ECG recording is going on, what is the speed, at which speed this paper is moving on the ECG machines? That is 25 millimeter per second. That is the standard speed of ECG recording paper. Now if you look at this ECG chart paper, there is a smallest boxes here. You can find out a smallest boxes here. Okay, this smallest boxes, if I magnify here, so this is the smallest boxes in the ECG chart paper. You know that this smallest boxes, it is a square, and length and width both of them are 1 millimeter, right? So this square has a length of 1 millimeter. I told you earlier that the speed is 25 millimeter in 1 second, right? So if I want to understand that what is the duration of this 1 millimeter, okay, so 25 millimeter in 1 second. So what will be the duration of this 1 millimeter? This is 1 upon 25, and that is 0.04 second. Getting my point? So the smallest boxes, if you take the smallest boxes here, okay, the 1 millimeter is equal to 40 millisecond, that is nothing but 0.04 second. That is nothing but 0.04 second. Now the y-axis of this ECG, so x-axis is the time axis and y-axis is the voltage axis. How much voltage is equal to this 1 millimeter boxes, that I have to understand. Now ECG machines is calibrated in such a way that if you are giving 1 millivolt to the ECG machines, okay, that will give you 10 millimeter deflection. That is the meaning of calibration. What is the meaning of calibration? Look at this. This initial part, this square shaped wave that is recorded before every leads, this is nothing but the calibration. If you count these boxes, these boxes will be 10. The smallest boxes, if you count here 1, 2, 3 like this, they are 10. That means 1 millivolt voltage will give 10 millimeter deflection in ECG on y-axis, that is known as calibration. So this part is the calibration. This is for standardization of the ECG across different recording system. Getting my point? So you are giving instruction to the machine that if you are getting 1 millivolt, give me 10 millimeter deflection. So this way, if I ask you what is the voltage of this smallest square, okay, on y-axis, then obviously this will be equal to 0.1 millivolt. 0.1 millivolt, 1 upon 10, that is 0.1 millivolt. So now I came to know that the smallest boxes which are present in the ECG, the x-axis is the time axis and this is 0.04 second, and y-axis is the voltage axis, this is 0.1 millivolt is the voltage, right? Now with this concept, if I ask you, can you calculate the heart rate? Answer is very easy, simple. So the speed of the ECG chart paper is 25 millimeter in 1 second. So in 60 seconds or in 1 minute, what will be the distance covered by this ECG chart paper? Simple, 25 multiplied by 60, that is 1500. That means this 1500 millimeter, okay, is the movement of the chart paper in 1 minute. So I have to count that within this 1500 chart paper how many QRS complexes appearing. But rather than that, if I measured the interval between this R wave to the R wave, that is the peak of R wave to the peak of another R wave, that is known as RR interval. If I count how many smallest boxes are there in between, so if I count like this, 5, 5, 5, 15, 17, 18. 18 millimeter is the RR interval here. So just dividing this 1500 upon this RR interval will give you the heart rate of the person. Very simple, okay. 1500, where from it is coming? It is coming from the movement of the chart paper in 1 minute, and within that 1 minute how many QRS complex is appearing, that I want to calculate. So how to calculate? Easily, RR interval, divide 1500 upon RR interval, that is your heart rate. Now this is very easy to calculate the heart rate if the heart rate is regular. But if the heart rate is irregular, like here in this strip you are finding out the heart rate is irregular, in that cases you have to take a long strip, maybe lead 2, long lead 2 recording, and in that recording you find out 6 second window. 6 second means in 1 second the ECG paper is moving 25 millimeter. So 6 second means 6 multiplied by 25, that means 150 millimeter. So starting from this up to this arrowhead, right, arrowhead is given here, starting from here to here, this is nothing but 150 millimeter. 150 millimeter, okay. Where from 150 millimeter is coming? 6 second multiplied by 25 millimeter, that is 150. So within this 150 millimeter chart paper or 150 boxes, smallest boxes, I am going to count how many QRS complex are there. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. So within 6 seconds I am getting 13 QRS complex. So within 60 seconds how many QRS complex I am going to get? 30 multiplied by 10, so that is 130. This is the heart rate of the person. Getting my point? So this way heart rate is calculated when the irregular in rhythm. Okay. Now the last part of this calculation is calculation of cardiac axis. So whenever I am saying calculation of cardiac axis, you know, it is nothing but determination of the main cardiac vector from ECG recording. So previously we have seen that when the initial vector is coming, then the main vector is coming, then the terminal vector is coming, and that is giving rise to QRS complex. Now I have to do the reverse one. From the QRS complex I have to determine what is the direction of the main cardiac vector. So please note down, cardiac axis means it is nothing but calculation of main cardiac vector. Main cardiac vector. What is the amplitude? What is the direction? That is the meaning of cardiac axis. So typically it is done from lead 1 and lead 3 recording. You can do it from lead 1, lead 2 also, lead 1 AVF also. 2 lead you have to take, okay. Generally I prefer from lead 1 and lead 3 because they are separated from one another, they are very away from one another, that's why. Otherwise you can take lead 1, lead 2 also. So if you think of the hexaxial referral system, then lead 1 is directed at 0 degree, right, and lead 3 is directed at 120 degree angle. We know this from hexaxial referral system. Okay. Now from this ECG recording I have to calculate what is the net deflection of QRS complex from this lead 1 and lead 3. So net deflection means, first of all I have to look at the baseline. Baseline means isoelectric line. Then find out how many positive deflection you are getting from here, 3, 4, 5, 6, 7, and how many negative deflection you are getting from here. So 1. So plus 7 minus 1. So net QRS complex deflection is plus 6. Right? Very simple mathematics. And similarly, if you go this lead 3, so this is the baseline. Above this baseline, how many? 1, 2, 3, 4. I have already counted. This is plus 13, and in negative direction minus 2. So suppose this is plus 11 is the net QRS complex deflection. Both are plus. So if both of them are plus, so I have to plot them on this direction, in this direction. Right? But if they are in negative direction, we know we have to plot them in the other direction. Right? Okay. So now just think of that this lead 1 and lead 3, they are placed on a graph paper. I have to plot plus 6 on lead 1, right? So suppose this is arbitrary 1, 2, 3, 4, 5, 6. So this is a point, this is plus 6. Okay. Similarly, I have to plot on lead 3 also. Lead 3 is plus 11. So this is 1. Suppose this is 5. This is 10. And this is 11. So this is plus 11. Suppose this is point B. Now what you are going to do? Now I am going to plot one perpendicular on this lead 1 axis from the A point. And I am going to plot another perpendicular on this lead 3. Okay, from the point number B. I am finding out at which point both of them are meeting. Now if I connect, okay, now if I connect from this center, just hold on, from this center, if I connect this cross section point, okay, this is nothing but the main cardiac vector, and this is nothing but the cardiac axis. Getting my point? So this is nothing but the main cardiac vector, this is nothing but the cardiac axis. So now I am finding out that if this is the main cardiac vector or this is the axis of the heart, then amplitude I can find out by this same manner. Suppose 1, 2, 3, 4, I can calculate the amplitude. But more important is that what is the direction or what is the angle of this cardiac axis with respect to 0 degree. So I have to find out what is the angle here. So suppose this angle is 60 degree approximately. Next question is whether this 60 degree angle is normal or not, means this cardiac axis whether this is normal or not. Remember, if this main cardiac axis is located at any point between this minus 30 up to plus 100, okay, plus 100, minus 30 up to plus 100, if this vector, if this main cardiac vector is located in any point in this angle minus 30 to plus 100, then that will be known as the normal cardiac axis. So obviously in these cases this is a normal cardiac axis. But if the cardiac axis is deviated beyond this minus 30 degree angle, then that will be known as the left axis deviation, and if it is deviated beyond this 100 degree angle, that is known as the right axis deviation. Right? So now look at, this is all about the cardiac axis. I told you that the main cardiac axis or the mean QRS axis lies between minus 30 to plus 100. Some of the books, like for example Genong, is saying up to plus 110 is also normal, but this is taken from Harrison, minus 30 to plus 100. Now if it is beyond, more negative than minus 30, more negative than minus 30, that is left axis deviation, and if it is more positive than plus 100, then that is right axis deviation. And the causes of this left axis deviation, according to Harrison, it may be normal variant also, It may be left ventricular hypertrophy, it may be left anterior fascicle block, or left wall, okay, inferior wall myocardial infarction. And for right axis deviation, it may be also a normal variant. It may be right ventricular hypertrophy, left posterior fascicle blocked, or lateral infarction. So this is all about your basic concept of normal ECG, how different waves are generated, how different normal measurement is taken from ECG. Now before concluding this session, I want to discuss another special variety of ECG that is known as His bundle electrogram. So first you remember, His bundle electrogram is an invasive ECG recording, not like that of the normal ECG. So this is an invasive ECG recording. So in this ECG recording, His bundle electrogram, you have to place your lead close to the AV node. What I am saying, suppose this is your SA node, right, and this is your AV node. After the AV node, we know that there will be bundle of His, right? So SA node, AV node, and bundle of His I have made. In case of His bundle electrogram, you have to place your lead close to this AV node. So obviously the lead is placed inside the right atrium, close to the AV node. So obviously you have to do an invasive procedure by which the catheter will be introduced inside the right atrium, okay, and this catheter tip will contain an electrode, and that electrode will be placed close to the AV node so that you can record detailed electrical activity from the AV node and bundle of His region, right? Okay. So now whenever the SA node will produce an impulses, we know that impulses will travel to the AV node. Whenever it is striking at the upper part of the AV node, it is striking means depolarizing the upper part of the AV node, it is striking here. Immediately it will produce a depolarization wave. That depolarization wave will be easily picked up by this lead and it will give a deflection like this, right? This deflection is due to starting of activation at the level of AV node, right? So that's why this is known as A wave in His bundle electrogram, right? Then we all know that this depolarization will pass through the AV node, right? It will take long time and then it will strike the upper border of this bundle of His. Whenever it is striking the upper border of the bundle of His, again it will generate a depolarizing wave, and that wave will be again recorded by this, okay, ECG lead. So this is due to His bundle activation. That's why the wave is known as H wave, right? Getting my point, upper border of the His bundle is activated. And then what? Then next this wave will also pass through this bundle of His, and now it is going to causes depolarization of septum of the ventricle. That is the ventricular muscles will be depolarized. Ventricular muscles will be depolarized after crossing the bundle of His. The septal muscle will be depolarized. So whenever ventricular muscle is again depolarizing, starting of depolarization, again this His bundle electrogram lead is going to record an activity, and that activity is due to ventricular depolarization starting. So suppose this is the wave, so it will be known as the V wave. So now I can understand that this His bundle electrogram contain three different waves, that is A wave due to activation of the AV nodal activation, right? Then H wave due to activation of the His bundle, right? And then it is also getting the V wave, and that V wave is due to ventricular muscle activation or depolarization, right? So the three waves. Now if I plot a normal recording of ECG, normal ECG along with this His bundle electrogram. So this is my HBE, His bundle electrogram. Now I am trying to correlate this with normal ECG. So normal ECG means it will record the P wave whenever SA node is starting activation of the ventricle, activation of the atrium, right? So P wave will appear earlier than A wave, obviously, because P wave means starting of atrium depolarization. So P wave will start a little earlier than A wave, and then there will be a long no activity, whenever ventricular activation is started in ECG, QRS complex will also start like this. Getting my point? So this is QRS complex, this is P wave. How I am drawing? V wave in his bundle electrogram means it will coincide with QRS complex. Okay, P wave atrial depolarization which will start earlier than A wave. Now, if I measure the time interval between onset of this P wave up to the onset of this A wave, so this is an interval. What will be the name of this interval? That is PA interval. If I measure the time between this A wave and H wave, that will be known as AH interval. And if I measure the interval between this H and V, then that will be known as HV interval. So simple thing is that this His bundle electrogram contains three interval, that is PA interval, right? Second is the AH interval, right? And third is the HV interval. Getting my point? Now you have to recall the previous discussion, that is the conducting system of the heart. In conducting system of the heart, we have discussed different time interval. I told you that how much time is required from this SA node up to this AV nodal transmission, that is 30 millisecond, and this 30 millisecond is nothing but equal to the PA interval duration. Getting my point? So PA interval is nothing but 30 millisecond, right? Similarly, if I ask you what about the AH interval? What is AH? AH interval means from here up to this bundle of His, how much time is required? This time is nothing but it is the time which is required to cross this AV node. So simple, AH interval is nothing but your AV nodal delay, and AV nodal delay is how much? This is approximately 100 millisecond. So AH interval is AV nodal delay. And similarly, if I ask you what is HV interval? HV interval is nothing but it is the time which is taken to cross the bundle of His. So that is His bundle delay, and we have discussed earlier His bundle delay is normally 40 millisecond. So combination of these three interval PA, AH, HV, it is nothing but starting from P up to the V wave. V wave correspond with QRS complex. So this is nothing but PR interval. Getting my point? So PR interval is nothing but PA is plus AH plus HV. If you combine these three, you are going to get a PR interval, because all of you know PR interval is starting from onset of P wave up to the onset of QRS complex, and in between all these things are happening, that is generation of the A wave, generation of the H wave, generation of the V wave. So we all know that pathologically, if the PR interval is prolonged, then mostly we know that this is heart block. There is block at the level of AV node or maybe infranodal region. But we do not know that whether this PR interval is prolonged due to problem at the level of AV node or at the level of bundle of His. Getting my point? So PR interval prolonged means there is problem at the level of either at the level of AV node or at the level of bundle of His. But if you have to pinpoint that where is the actual block, the block is at the level of AV node or the block is at the level of bundle of His, you have to do this His bundle electrogram, and you have to look at this interval, that whether this interval is prolonged or HV interval is prolonged, and accordingly the diagnosis can be pinpointed. So this way the His bundle electrogram, which is an invasive electrogram, is taken. So this is the diagram I have taken from Genong. This is A wave, H wave and V wave, and this is the normal ECG. And another diagram I have taken from a journal article. So here you can find out that where the lead is placed. So this is the placement of the lead close to the AV node and bundle of His region, and this is the actual recording. So you can find out here the A wave, then H wave, and then V wave, and from this recording different intervals are calculated and diagnosis is done. So this is all about basic concepts of ECG.